So welcome, Dr. Nock.
Thank you, Lisa. So this is a really interesting time for research into celiac disease, gluten sensitivity, the gluten-free diet. So it's really an emerging area of interest and understanding. So I'm going to review what we know about it and then touch upon kind of the areas that are still controversial and what we still have to learn about it. So to start out with the definition of what is celiac disease, it's a malabsorption disorder in the small intestine that occurs after someone eats gluten in a genetically susceptible individual. And we'll talk all about what that means. First of all, what is gluten? Probably many of you are familiar with it at this point. A few years ago, no one really even knew that term. Now it's much more common knowledge as we hear about it and have more products in stores that are considered gluten-free. So gluten is wheat, barley, and rye, and it's a common filler in many ingredients, which makes the gluten-free diet particularly challenging. And some of you might be wondering about oats. We used to say wheat, rye, barley, and oats was part of gluten. Oats are not actually gluten, and if you prepare them in a way that keeps them away from cross-contamination, they are a gluten-free food. The problem is most ways oats are prepared, it's in the same vats and whatnot that wheat is processed. So oats by themselves naturally are a gluten-free food. So there's a few things you need to get celiac disease. One, you need to be genetically susceptible to this. So the majority of the population just doesn't have the genes that make it possible. And we'll go into details about what we know about the genetics of celiac disease. So it needs to be a person that has a susceptibility towards it. They need to be eating gluten. And this is of interest since in many parts of the world, people didn't eat gluten until now. So a lot of areas where people didn't naturally eat gluten, they had rice and other starches in their diet, we didn't see celiac disease. Now that really everywhere in the world the diet sort of is changing and people are eating more gluten, we know that it's really common everywhere. But of course you need to be eating gluten to develop this problem. And then 3, this is the mystery and where there's some controversy and there's emerging research in what takes a genetically susceptible individual who's eating gluten and turns on the process that causes celiac disease. So why do some siblings get it, some don't? And it's thought a variety of factors might do it, that there might be a diarrhea illness that caused some breakup in the intestinal wall that allowed more exposure to gluten. It's not really known what that inciting event is. But we know not all people who have a genetic susceptibility who eat gluten get it. So there's something in this third category that is yet to be understood about why it's turned on in some people. So I'm going to just do a brief history of time with what we know about celiac disease. So the term celiac actually comes from the 2nd century AD, where they described it as a chronic diarrhea. They didn't have any idea what caused it, but this was really the first term of celiac disease. And then we kind of fast forward to the 1880s was the first link to diet, is that physicians at that time figured out this chronic diarrhea that was called celiac disease had something to do with what people were eating. In the 1920s, there was experimentation taking these patients and trying to figure out what the diet was, but they didn't figure it out until World War II. So in the 1940s in Europe, there were times where there were bread shortages. And there was a Dutch pediatrician that took care of a group of children with celiac disease. And during the bread shortages during the war, his patients remarkably got better. And so that was really, under those circumstances, is how they began to figure out that it was gluten. In the 1950s, they really perfected how to diagnose it by doing what's called an endoscopy, where they put a camera down through the mouth into the small intestine, take a biopsy, a sample of the small intestine, and look at that tissue under the microscope. So in the 1950s, if someone was going to get diagnosed with celiac disease, they had to go through that whole procedure to get the diagnosis, so that's how it happened. And that's when they began to look under the microscope and really come up with some classifications of what's considered celiac disease. In the 1970s, they came up with some blood tests where they could screen larger groups of people who might have symptoms and maybe select the positive ones and do the further testing. The problem with the blood tests in the 1970s, these were called the gliadin antibodies, they were very bad. They were just poor blood tests. They would miss a lot of cases or they'd have a lot of false positives. So there wasn't a great practical approach until the 1990s. What happened in the 1990s and what really changed the direction of the understanding of this disease is that there were some better blood tests developed. And with those better blood tests came large research studies that really began to understand more about this illness. So it was really the development of those better blood tests that kind of exploded the research into this field. And we'll talk about what we've learned. So back 50 years ago, what they would call someone with celiac disease was someone, what we refer to now as the classic presentation. So this was someone that had an obvious chronic diarrhea, usually thought to be a child. They'd usually have anemia, they'd usually have weight loss. These were very sick kids. And the picture, to give you a sense, is also, they thought of it as a Caucasian illness. So this was thought that some European children get this, they get very, very sick, and again, the biopsies and everything that happened in the 1950s were on this type of case. Here's what we know now that we have those better blood tests and we could really test more people. What we know, what we call the atypical, and I put that in parentheses because this is actually way more common than those smaller subset of classic cases, which were the really sick kids that were kind of wasting away with diarrhea. What we know is more typical is what we call the atypical presentation, which might be mild or no symptoms. They might not have symptoms in their GI tract, but have other types of symptoms. We'll go into what that can be. And again, they might not have symptoms, just some abnormal lab tests that they get on abnormal labs, anemia and things like that. What we also know, because there was so much widespread testing and research, is that you can present at this with any age. It's not a pediatric illness, it's not a childhood disease. Someone who's 80 years old could have an inciting event that triggers their newly found celiac disease. So it can occur at any age, and all races are fairly equivalent. So it's not a Caucasian illness by any means. Some of the symptoms inside the GI tract, besides just that classic chronic diarrhea, is canker sores, there's some teeth enamel changes, abdominal pain, bloating, even some constipation or diarrhea. So really a wider spectrum of how someone could present with not just diarrhea. A word about the diagnosis we call irritable bowel syndrome. About 15% of the US population has this label, meaning meets the criteria for irritable bowel syndrome, which is someone who has either diarrhea, constipation, or sort of a mixed picture. So they're not really regular. They have a lot of abdominal pain and bloating. 4% of patients diagnosed with this irritable bowel condition actually have celiac disease, compared to 1% of the overall population. And 36% of people with celiac disease had a prior diagnosis of IBS, meaning they went to the doctor with some symptoms, were diagnosed with IBS, later found to have celiac disease. Now, I said that often the case is someone presents not with a symptom in their GI tract, but in another way. And this might be fatigue, it might be joint pain or arthritis, it might be premature thinning of the bones or osteoporosis. It's even linked to some anxiety and depression, which is thought to be, if you lack certain B vitamins and things, you can have some psychiatric symptoms and sort of depression and anxiety. Women can have infertility, miscarriages, And then there are some symptoms in the brain and the spinal cord, which is, there's something called ataxia, which is a balance problem, seizures, neuropathy, which is a numbness and tingling of the skin, migraines, restless leg syndrome. So a patient may have just one of these neurological symptoms and not any of the GI symptoms. So it makes this story much more complex. Again, some patients have no symptoms. They just get routine labs and are found to have some lab abnormalities that can't be explained in other ways. So anemia due to iron deficiency, about 2 to 15% of celiacs present that way. Folic acid deficiency, low calcium, low vitamin D, and high liver tests. It's not quite known why the liver tests go high in celiac disease. It's thought it's part of if someone has untreated celiac disease, there's a lot of inflammation in the body which can attack the liver and cause these high liver tests. And adults, if a child presents, they are more likely to have that classic picture of diarrhea. If an adult presents, they're more likely to have this atypical presentation of these other symptoms we were talking about. And 20% of the cases that are now diagnosed are in people older than 60, so it's really not a childhood illness. And although some of them might have had disease for many decades, some of them only recently have gotten symptoms and kind of had the disease turned on or activated. So they really can present with it at any age. So because of this story, researchers in this field came up with the idea of the celiac iceberg. So the classic presentation that we thought of was really the tip of the iceberg, and that more people have an atypical presentation, and then silent celiac disease where they don't have any symptoms, but maybe some lab abnormalities and things like this. So it's a really much larger spectrum than what was previously thought. So again, to recap, how common is it? It's not confined to Caucasians, and the prevalence is about 1% worldwide. Now, one issue is most doctors practicing today practiced and went to school at a time where we didn't have those blood tests and whatnot, so a lot of physicians are still thinking of celiac disease as that classic presentation. So it adds to the difficulty in diagnosis if they haven't kept up with these recent changes of all the different ways someone can present with celiac disease, which makes it very hard sometimes for patients to get diagnosed. This was a landmark study out of University of Maryland that really changed the way here in the US we thought of celiac disease. It was a huge study that used these better blood tests that were developed in the 90s to find out how common it is in the United States. And that's where we learned about 1 in 100 or 1% adults have it. If we look at first-degree relatives, so if someone has celiac disease, how likely is it, if brother or sister is going to have it? About 1 in 22 in this study. Some other studies have shown it might be about 1 in 10. Second-degree relatives, about 1 in 40 in this study. Some studies show about 1 in 20. People that had symptoms that might fall into the categories we talked about, it was about 1 in 50. And then the group that really had no risk factors, it was still quite common, going about 1%. And what we learned also in this study is only 35% had diarrhea. So again, it kind of shows that that classic picture is not the common way that people present. And different racial groups were really very similar in the rates that were detected. So to recap, it's common. It's 1% of the population worldwide. It can have a variety of symptoms. It's underdiagnosed. And then what I think is very interesting and is a kind of new twist to the story